Hi, welcome. My name is Dr. Erica Spatz, and I'm a deputy editor at JACC, and I'm delighted to spend this time today with Dr. Naveed Sattar, who's a professor of cardiometabolic medicine at the University of Glasgow. Welcome, Naveed. Great to see you.
Yeah, hi, Erica. Nice to see you.
So, we are here to talk about a review paper, which is really a roadmap around designing next generation cardiometabolic outcome trials for obesity medicine. This is really a guide on thinking about where we are now and where we need to be going in the future. Tell me a little bit about what motivated this paper.
Yeah, sure. I guess the first motivation is I think we're all recognizing that obesity is driving lots of long-term chronic conditions, including cardiovascular conditions. And in recognition of that, Fayez Zaned, who's one of the senior authors on this paper, along with myself and Elke Platz, we decided to sort of present stuff at the CVCT conference on obesity and amongst regulators, amongst trialists, to discuss the issues relating to this new wave of incretins and incretin-like drugs and the need for outcome trials and how fast the evidence has evolved and how much more we need to think about the expansion of endpoints in those trials beyond MACE. We've been far too MACE-centric for the last 30 years. We've got to move beyond that. It's time to go well beyond MACE because actually, if you look at the epidemiology, MACE has been coming down. It's the non-atherosclerotic stuff that's been going up. Heart failure, aortic stenosis, arrhythmias, thromboembolic disease. And that's where the big issues are nowadays. So we've got to think bigger, better, and plus, these drugs seem to be having effects on all these various outcomes, not just MACE, and outcomes even beyond cardiovascular disease in terms of the kidneys, in terms of metabolic. So we've got to think bigger, and we've got to bring the readers with us, we've got to bring regulators with us, and we've got to bring trialists with us to maximize efficiency.
One of the areas that you propose is to put an end to these placebo-controlled trials. I think there's no surprise that we see these kinds of outcome, both weight loss, intermediate outcome changes in terms of cardiometabolic risk factors and outcomes with comparison to placebo. What are some of the key questions that might inform more head-to-head trials that you see being important to advancing this field?
Yeah, I mean, it's clear that actually we're not going to do away with placebo-controlled trials, at least in the next few years. There will still be a few generated. That's partly because even though the drugs are being used widely, there's millions of people around the world who don't have access to the drugs. So placebo-controlled trials generally can be smaller. They generally give us a purer result against placebo, which we can all understand. Whereas active controlled trials generally have to be larger to get the power. They're often based as non-inferiority. They're harder to understand. But the benefits of active controlled trials is, particularly in high-income countries like the US and Europe, is that you have far less dropout because you're giving everybody the drug, which I think is really important. And and I think, but there are downsides to it as well in terms of the power, design, the interpretation. So there's pluses and minuses of both. I think over the next 5 years, we will transition more towards active controlled trials, particularly when we have 4 or 5 drugs which are licensed, which are being used increasingly all over the world. And we can't keep doing placebo-controlled trials because it becomes simply unethical. The other way to actually help placebo-controlled trials at the moment is having open label extensions. So we help the patients through the trial as best we can, improve their care, even if they're on placebo, but we then offer them the drug at the end of the trial. So there's lots of considerations going on, but we're in that kind of phase of transitioning or thinking about active controlled trials. And obviously, Surpass CVOT has just been published and as the first of this kind of nature. And there will be, I think, several more designed over the next few years.
Thanks. There's a lot of interest in lower dose incretin therapy and whether we should be treating to target versus, can we derive cardiovascular benefits at lower drug doses? How would that, what are your thoughts on that and how might that inform clinical trials?
Yeah, that's a really difficult question at the moment. In a part because we don't quite know how the drugs are lowering some aspects of the disease. We believe that the drugs' effects on heart failure, at least I do, and many others, and blood pressure, and certainly to some extent diabetes and kidney disease are largely or predominantly weight related, but there are also direct effects on probably atherosclerosis. What I think most trialists are currently thinking about, I just don't think we have enough evidence, is that can we give them the maximally tolerated dose of the drug that can be given safely, that the patient is happy with at the weight that they achieve at the moment, rather than going for low doses. What I would say, we have a few clues that there may be dose dependency. One of which is, for example, the Amplitude O trial, which Hersel Gerstein read. I was involved in the executive committee, and we saw a clear difference between the 4 and 6 milligrams in terms of the benefits on cardiovascular outcomes. So that there could be a dose-related effect, but to show efficacy of the drug at the moment, particularly if you're putting a lot of money and if you're doing active comparator, you really want maximum tolerated dose just to show that efficacy. And then we can work backwards. If we know it works well and it's safe, and I think if you step back, the biggest thing that most patients want nowadays is actually to feel better. They want to know that it's safe and maybe they get cardiovascular benefit. But if it's safe, if they lose weight to a meaningful extent, they generally are happy because with the weight loss comes better ability to do activities of daily living, perhaps walk more, to feel better, to look better, and to have less joint disease and the simple things, less fatigue. That's what patients want. We're all driven academically. We want to look at this endpoint, that endpoint. No, wait a second. Let's do the trials so that the patients are maximally tolerated dose that they're happy with, that they don't have side effects, that the weight doesn't go too low. And that's what we should try and aim for, I think, increasingly as well.
You captured so much of what we experience every day with patients. So I think a lot of us are making assumptions based on that early split in the curves of MACE in the SELECT trial, questioning whether there's cardiovascular benefit really at these low doses, and should we be using these medications even in populations without obesity to derive cardiovascular benefit. And so that kind of leads me into my next question, which is around, what are the inclusion criteria that we should be using? Should we be focused on BMI as necessary for inclusion, or are there other metrics that we should be looking at to enroll patients in clinical trials who may derive some of these cardiovascular benefits?
Yeah, no, that's a great question. Let me answer it in two parts. Number one, BMI is still pretty good, particularly when you have a BMI above 30. There's a lot of debate around the world, but actually, once you have a BMI above 30, in the vast majority, waist and waist to height ratio are collinear beyond that. So they're telling you pretty much the same information, particularly if you have people with BMI above 30 and existing disease. They've told you they've already got the disease. And it's the same true for people 25 and above. If they've got the disease that you're interested in, well, they've got the disease. Whatever the weighting of risk factors, one of which might be being overweight, they've still got the disease. And the question is, does the drug lower risks in those individuals? And is it to a great extent a direct effect of the drug versus the weight loss? I don't know. What we need to start off with is a huge population of people living with obesity all over the world. So there's enough patients to already treat now with obesity, with all the assets coming through from different companies to do those trials. But at some point, we will move on to the lower risk, particularly in low and middle income countries, such as South Asia, Afro-Caribbeans, China, where people get disease at lower weights, particularly metabolic disease, and with that comes a cardiovascular disease. And it looks like, for example, people like myself, South Asians, they have bigger waist circumferences for the same BMI. So perhaps we can recruit in those populations, not just based on the BMI, because they tend to be lower BMI, but also waist circumference with an existing disease. So that's, I think, the way it's going to move forward. But I wouldn't, for the listener, I would not denigrate BMI too much. It's still going to be the major use criteria for most trials, at least for the next 5 years, in my humble opinion.
Thank you. That's really helpful. And I love that approach of being strategic around high risk, vulnerable populations when we think about the public health effects of obesity, really thinking strategically about, who's at risk and how do we use these medications in a responsible way. So it sounds like we're going to continue to use BMI 30 and above. That is a good measure of who is likely to benefit. They also have high visceral adiposity and then maybe some of these subpopulations that we can target where BMI is not reflective of the risks of adiposity that they experience.
I mean, I think it's partially reflective, but that you get more information in some populations by looking at waist or waist to height ratio. So and then we'll see how the evidence evolves, and then we'll retrack and make further guidelines. And it may well be that once you've got BMI, but you've got existing disease, you perhaps don't need the other things. I don't know. And most people are happy to get weight and height measured. Some patients don't like to get their waist circumference measured, and some physicians don't like to do it. So, there's a lot of issues there that beyond just a simple academic is it should be measuring it.
Right. That's real world medicine for sure.
Yeah.
And the other part of the response that you had was really around the patient-reported outcomes. In terms of how do patients feel, what are they able to now do? What other areas of, body aches and pains that they experience? Are these areas that we as cardiologists should care about and look for in our clinical trials?
Absolutely. Now, here is the big problem that obesity has led us to. We have done really well in many high income countries by keeping people alive longer, reducing CVD death. And that's fantastic. But at the same time, obesity has been going up. And guess what? More people are living longer with more life years, with more obesity, particularly older people who've got vulnerable organs, susceptible organ systems that become more badly affected by obesity. And we have now patients in our 80s living with weights of 120 kilograms, which has never existed before. And then guess what? They get heart failure, they have kidney disease, they have hypertension, they have sleep apnea. So we have this cadre of long-term multiple conditions of multimorbidity. We can't just think in our silos anymore. And I think this is what the paper is saying. In cardiovascular disease, we've got to go beyond just MACE. We've got to look at non-atherosclerotic outcomes. Look at revasc, look at heart failure, combined outcomes. We say that in here. And maybe even more than that, we've got to look at PROs. And maybe there's also an additional, which we maybe didn't put in the paper. What about secondary outcomes that looks at all-cause hospitalization or other aspects? Because these drugs, by tackling weight, are affecting multiple outcomes beyond our domain of cardiovascular outcomes, multiple outcomes. And what matters to patients is they want to feel better, they want to have recovery from disease, and they want to develop less future disease. And somehow the regulators have to get on board with that, and trialists have to get on board with that. And we have to speak to each other so we have very efficient trials that capture the endpoints that save costs, reduce suffering in much more holistic manner. Because if we just think about reducing MACE and MACE and MACE going forward, we're actually going to get more multimorbidity. And we can't do that anymore. The world has changed and people need to recognize that. And I think this paper is trying to push and help all of us get to the same page of where we are in trial considerations. It will evolve even further beyond this paper. Many people read it, will have even better thoughts, and hopefully all of us together will evolve and get better trials that capture much more holistic outcomes for the benefit of ultimately of patients and communities and society.
Dr. Naveed Sattar, it's been such a pleasure to hear you talk about this field. Thank you for being a leader and opening up our minds and our ideas into how we can move this field forward to improve patient health as well as public health. So thank you so much for joining us today at JACC, and thank you for all your work in this area. Congratulations on this paper.
Absolute pleasure. Thank you.